And without further delays, the title of the presentation is Perspectives of Rehabilitation Professionals Intervening in Long COVID Rehabilitation with the Goal of Returning to Work. We'll invite Tania to explain a little bit more about this project, and then the students will start presenting. Thank you.
Thank you, Lucas, and good morning, everyone, or good afternoon. My name is Tania Janaudis-Ferreira. I'm an associate professor with the School of Physical and Occupational Therapy at McGill, and also a scientist with the McGill Universal Health Center. And today, I have the pleasure to let these students, they will introduce themselves, I hope. And this is part of it's a presentation that is part of their course, the POTH 624 course, that it's a master's project. So as part of their program, these are actually OT's students. And as part of their program, they do this course and they have to conduct a research project. And then at the end of the project, they write a manuscript and they do two presentations. One presentation at the clinical site, if they have done a research project in collaboration with clinicians, and another presentation at the School of Physical and Occupational Therapy. So today is the presentation at the clinical site. And I have co-supervised them with Vanessa and Mayuri, and I will just let them begin. And I'm looking forward to hearing what they have to say. And again, please feel free to ask any questions you may want at the end, give feedback, because they are in the process of writing their manuscript. So your questions, your comments, and feedback will help them shape the discussion of the manuscript. So it will be very, very helpful for them. Thank you, and you may begin.
Thank you, Tania. So good afternoon, everybody. I just want to thank you all for hopping onto this Zoom and joining Cassandra Castro, Cassandra MacKinnon, and myself, Alexandra, for the presentation of our master's research project. So as Lucas said, our project is entitled Perspectives of Rehabilitation Professionals Intervening in Long COVID Rehabilitation with the Goal of Returning to Work. So we will begin by providing some background on the topic, followed by the rationale for our study, which will then lead into our methods, our results, and we'll end with some important findings. So let's dive into the introduction with some background information on long COVID. The condition has been defined as the continuation or development of new symptoms 3 months after the initial SARS coronavirus 2 infection, with these symptoms lasting for at least 2 months with no other explanation. According to the Canadian COVID-19 Antibody and Health Survey, almost a third of Canadians aged 18 years and older have indicated that they have tested positive for COVID-19. From this third, 15% still had lingering symptoms 3 months after their initial infection. And these symptoms included fatigue, cough, shortness of breath, and brain fog. Here we've included post-exertional symptom exacerbation, also abbreviated as PES, which is a worsening of symptoms and reduction in function following an activity, whether it be physical, emotional, or cognitive. And the PES is predominantly characterized by a malaise or fatigue post-exertion that can be debilitating for hours, days, or weeks. Seen as the symptoms of long COVID can be very persistent, the condition leads to a significant decrease in overall function over a prolonged period. So not only does this mean that long COVID, and that includes work also. So this decrease in function does affect work life. So long COVID population has to be off work, but they also have a prominent delayed return to work. So this population could benefit from rehabilitation to reduce the burden of symptoms and as well as optimize function and with the goal of returning to everyday activities. So the current recommendations provided by institutions such as the Alberta Health Services and the World Health Organization highlight patient education and energy conservation principles as key interventions. This would include recognizing individual symptoms and triggers of PES, as well as identifying activities within tolerable limits. So those would be activities that wouldn't cause a symptom exacerbation. while these recommendations are based on a combination of expert and evidence, we could go to the next slide. Sorry. There we go. Before. Okay. While these recommendations are based on a combination of expert evidence and evidence applied from comparable health conditions and disease processes, there's no evidence on the effectiveness of these recommendations for long COVID rehabilitation, especially for PEDs. And there are also no specific guidelines for exercise and activity progression. So seeing as long COVID is an emerging condition with an increasing prevalence in the rehabilitation field, there is a need to establish best practices to optimize recovery and promote sustainable return to work trajectory.
So with the gap in mind, the purpose of our study was to explore the perspectives of rehabilitation professionals intervening in long COVID rehabilitation with the goal of returning to work. So it was really to get a direct perspective from these professionals to see what kind of treatments or interventions that they've been using, what has been working and what hasn't, and also the challenges that they've been facing during this rehab. So our specific research questions, we have 4 of them. The first one being, what are the treatments and interventions being used in rehabilitation professionals to help re-engage their clients in their work? What are the criteria being considered by rehabilitation professionals in deciding whether or not a patient is ready to go back to work? Our third question is how progress of functional capacity in clients with long COVID is monitored by these professionals for a return to work. And lastly, what are the challenges to rehabilitation and sustainability for working clients with long COVID from the perspectives of rehabilitation professionals. So now diving into methods. So the study design of our study is a cross-sectional qualitative study that uses the interpretive description methodology. So this methodology specifically really aims to address current gaps in clinical practice and further knowledge about a specific topic, which is exactly what we were trying to do with our question. Our study population are rehabilitation professionals, specifically physical therapists, occupational therapists, and kinesiologists in the province of Quebec who have specifically worked with the long COVID population. So in our population, these professionals were from either rehab centers or private clinics. The inclusion criteria in our study was that these professionals, whether they be OT, PT, or KIN, had to be licensed, and that they have worked with long COVID patients either in person or remotely in the province or Quebec. And lastly, that they had to be proficient in English or French. For the exclusion criteria, it was any rehab professional that did not work with the long COVID population, or if they had worked with the population, but for less than 3 months. For the sampling, we use purposive sampling in order to gain a wide range of views from these professionals working with the population. So the students, so myself and my 2 colleagues, as well as our supervisor, Tania, we emailed people who we knew that had worked with this population specifically, and we also posted on social media using an infographic. Our sample size was expected to be between 8 to 12 participants because based on the research that we had done, 12 interviews was expected to reach saturation. And in our study, we had a total of 9 participants. So these are the infographics that we used for our sampling, and 1 in French and 1 in English. So for the data collection, at the beginning of each interview with each participant, we collected demographic data that was not recorded in the interview. What we recorded was age, sex, profession, place of work, either be public or private, number of long COVID patients that they have worked with so far. This was most of the time an estimation. The years of experience in their profession, in their current workplace, but also with the long COVID population. We also conducted semi-structured interviews. So this was done individually with each participant over Zoom. There was 1 main student interviewer, and the other 2 students would remain there as observers and take notes and ask questions if deemed appropriate. We used a guide of about 8 questions, both open and closed-ended. We usually followed the order, but if not, we went according to the conversation with the professional. The interviews lasted between 23 and 60 minutes with an average of 43 minutes. And we had a total of 7 interviews in French and 2 interviews in English. So for the data analysis, we used thematic analysis. We used the 6 steps proposed by Braun and Clark. So the first one was familiarizing ourselves with the data. So we each assigned each other interviews to transcribe. So this made us review all the information that we had gained in the interview and then transcribe it on Microsoft Word. Then secondly, we generated initial codes. So to generate these codes, we used the Deduce software. We did this individually again. We ended up with similar codes as we were coding. And then based on these codes that we generated in the second step, we then searched for themes. So again, we did this individually to try and come up with 5 themes each other. And then we regrouped to discuss about these themes, talked about the ones that we had in common, and just agree on the ones that we could keep and that would reflect the codes. Then for the first step, we reviewed the theme. So we identified sub-themes and did a map on Deduce. Then for the 5th step, we analyzed the identified themes. So we just made sure that we went in depth and also named them properly in a way that they would convey the information that we had grouped so far, but also that was in direct relation of our research questions. And lastly, in our 6th step, we're still in the process of writing a manuscript in a way that is clear and concise and that can be easily read by the readers.
Okay, so moving on to the results portion of our study. So the study included in-depth interviews with a diverse group of 9 rehabilitation professionals working in various centers and clinics in the province of Quebec. So our study included 9 male and 8 female, ages between their 20s and their 50s. We had 5 OTs, 3 PTs, and 1 kinesiologist participate in our study, 2 of which were from the private sector, and 2 of them were from the public sector, from various regions in Quebec that you see on the slide. They all had varying levels of experience in the profession, in their workplace, and also with the long COVID population itself, as you can tell from the varying number of long COVID patients treated at the time of interview, between less than 10 or even more than 100. So our results led to 5 main themes to be identified, which I will go in more depth in the following slides. So first of all, starting with the reassessment of rehabilitation goals. Our participants expressed that return to work was hard to attain in long COVID rehabilitation and generally made a long-term goal, as exemplified by these 2 quotes from participants. The first one is a response from one of the interviewed participants to a question we asked regarding whether or not return to work is a goal that they establish with their clients. They said yes, but is it achieved at all the time? No, they want it, but that's what's hard because their daily lives are already difficult. So yes, they have it as a goal, but we don't make it a priority because they have to be able to do their laundry, make lunch, and pick up their child from daycare before they can say, I'm going back to work. This other participant also said further, in fact, all our patients, that's their ultimate goal, but it's like stairs, and returning to work is at the top. The professionals added that patients must be functional at home before being able to tackle work. One participant expressed that effectively what we're going to do is recommend a return to work only if the person is able to do half a day of activity at home that simulates work tasks without causing post-exertion discomfort. Then often the most we're able to achieve is 1 hour or 1.5 hours. So we never get to the point where I'm able to safely recommend a return to work. And overall, to be able to return to work in the long run, work accommodations are absolutely necessary, and the rehabilitation itself requires a lot more time than with other types of clienteles, as exemplified by rehabilitation professional number 5, when they said, usually I'll make a return to work plans over 8 weeks. For other clienteles, for example, with long COVID, I often go to 16. Education was unanimously brought up as a central intervention for long COVID rehabilitation, with topics ranging from generally understanding long COVID and its symptoms, energy conservation, breathing techniques, sleep hygiene, pain management, emotional regulation, and stress management. Some participants preferred to use a group format for the education component of their rehab programs, while others preferred to use individual. But ultimately, regardless of the format, what participants highlighted the most is that this education must be done as early as possible to help build their toolbox to properly self-manage their condition. This participant stated here, we work a lot from the perspective of self-regulation and self-management of one's health condition. So we'll be working on tools that will enable the person to understand his or her condition and develop a toolbox to help manage these signs and symptoms. So ultimately, the client is really seen as the expert of their own condition when it comes to long COVID. And acceptance was brought up mainly by many as a key factor for successful self-regulation, which might also be something to be addressed early on with clients. As this participant said, there are a lot of acceptance challenges, you know, in the sense that often people will have the tools, they'll know, that they'll understand, but it's going to be difficult to implement the changes in everyday life. Another way rehabilitation professionals can facilitate this self-management of the condition and like they're having their clients report back on how they're feeling is by encouraging the use of various tools. Like this participant mentioned here, we encourage them to use occupational journal, to follow their symptoms, to use the Borg scale to follow their dyspnea, to measure their heart rate, to also find out what's the limit they can tolerate and when it's safe to add some more reactivation. Many rehab professionals claim that the primary goal of long COVID rehabilitation is to promote autonomy and optimize function. This is done by progressing basic activities, for example, ADLs and IADLs, so activities of daily living and instrumental activities of daily living, at home instead of prescribing specific exercises. As this first participant stated here, when we've integrated quite a bit of ADL and IADLs, we can now think more about work and start doing simulations and strengthening tasks. The client's self-management role continues to be important here, as exemplified by this quote over here. To ensure patients are well informed to take on this self-management role, many professionals added that working together in multi or interdisciplinary teams, or even referring their patients to other health professionals can be really beneficial. Participant 4 here said that professionals to think about could be massage therapists, osteopaths, acupuncturists, of course, PTs and OTs, nutritionists, and psychologists. When it comes to the theme of progression of interventions and dealing with post-exertional symptom exacerbation, what came out from our data is that the two go hand in hand in that the presence or absence of a PES can dictate whether or not progressing interventions is warranted. This participant said once the symptoms have stabilized, i.e. once there's a reduction in post-exertional malaise and a faster recovery from post-exertional malaise, that's when we can make gradual progress. Rehab professionals go by trial and error in progressing interventions, and most of them prefer to wait for a certain period of stability to arise before they continue on further with the progression. When asked about what parameters they use to progress interventions, most mentioned that they favor increasing by duration and frequency before working on intensity. And when it comes to post-exertional symptom exacerbation, rehab professionals mentioned that they work with clients to help them recognize their symptoms and identify the triggers. This participant explained that to do that, they can use a symptom journal. I'll ask the client to fill in a symptom journal so that we can really keep track of what's going on, and so that they too can better understand what they're feeling and when they need to take action. So really like monitoring how specific tasks or activities are making them feel. Our last theme was regarding challenges in long COVID rehabilitation, which is really tied to a major objective for our study. The first challenge that was identified in our interviews was the recency of the condition and lack of clear recommendations for rehabilitation. There isn't much documentation on long COVID. It was especially difficult to know how to carry out our interventions with this population. We also had to get rid of the idea that you have to push yourself really hard to improve your capacities. You had to go much more gradually. In our interview guide, we asked our participants how they overcame these challenges. And for this specific challenge, many replied similarly to this participant here, to actually look for other resources to help us with this. A lot of soft learning too, reading the research, trying to talk to other therapists who too work with the long COVID population. The second identified challenge was the need to deviate from standard rehabilitation protocols due to the complexity and multiplicity of symptoms at hand. It's really a hard concept to understand that they have to limit themselves. And it's not the usual typical rehab that you have to like have goals and always do more. You know, it's really less and trying to find the limit or whatever you can tolerate. It's hard for the patients themselves. hearing out and listening to the patient and constantly just taking on this active listening role was really stated as an important measure to overcome these challenges among our professionals. Finally, dealing with misinformed and uncooperative third parties, such as employers, insurance companies, and even physicians who don't understand the particularities of this condition and how it impacts the rehab context. This was really our major third challenge that was identified. So a lot of educating and advocacy must be done to overcome this. As stated here, we've got a lot of advocacy to do. We've got to demonstrate why and explain why we're doing this, and then try to influence the decisions that are made to facilitate the client's return to work. So moving on to some important findings that arose from these results. First, looking back on the insights the participants gave us on return to work with the long COVID clientele. So while the participants unanimously highlighted the significance of having return to work as a goal, because when we think about it, most of these professionals work with clients who were off work. It is important for these clients, who are currently off work, but they also all agreed that it was generally not attained within the time that they were working with these clients. This consists in a really surprising finding for a study, as it further stresses that the episodic and unpredictable nature of long COVID leads to this extended, non-linear return to work trajectory. And thus more time is needed for rehabilitation to achieve successful return to work outcomes.
As Cassandra mentioned in the results section, education is a key intervention in long COVID rehabilitation, with an emphasis on early education to limit the worsening of symptoms. Expanding on this point and to highlight the effects of education, more than half of the rehab professionals mentioned how individuals who developed long COVID in the first waves of the pandemic had more intense symptoms, especially PES and fatigue, and they displayed poor energy management skills, likely due to the fact that there were no education materials for long COVID at the time, that it was just so new that no one really knew about it yet. No one could tell them or show them how to respect their tolerable limits. So they were constantly pushing themselves and experienced symptom exacerbations. And over time, this worsened their symptoms and likely even worsened their prognosis. As rehabilitation professionals shared that these individuals progressed significantly slower than someone who received rehab services earlier on, and it was much harder for them to return to ADLs, let alone return to work. As for the recommendations, rehabilitation professionals often avoided increasing activities when their clients were experiencing PES, which is consistent with existing guidelines. Many of them took on a more conservative approach, being very slow in their progression. And due to the unpredictability of the long COVID symptoms, rehabilitation professionals and clients work together to frequently monitor the symptoms for any changes throughout the process. Also, while rehab professionals seem to unanimously agree that to only increase effort after a certain period of stability, there was some inconsistency in what the length of this period of stability should be. So some mentioned waiting a week of stability before increasing effort, seeing as PES can appear 12 to 72 hours after effort. So this would allow them to see if that one activity would cause any symptom exacerbations. Others waited 3 to 4 weeks, which could ensure that the activity is within tolerable limits, even when performed multiple times in a given time frame. So while there's different reasoning for both options, the difference in length could also be due to factors outside of the professional's control, such as how many weeks of rehabilitation has the client been permitted, or how quickly is a patient expected to return to everyday activities and work. So some may not have the option to wait a month prior to slightly increasing exertion levels and prolonging the rehabilitation period.
And lastly, a major finding was educating other professionals. So as rehab professionals, a lot of them had to communicate with other third parties, such as CNSST agents. And what it's important to understand is that the agents usually have a predetermined time frame for a return to work given a diagnostic. However, this is not the case with long COVID because first of all, we don't know because of how new it is, but also it has to be done in an individualized manner. So in order to address this and educating these parties, it would be to just rely on literature and what we have found so far, and just provide them with facts in order to perhaps extend the return to work or provide even more accommodations. We also can educate other professionals such as physicians, because as we mentioned earlier, a lot of them don't necessarily refer to rehab. In fact, a study showed that only 21% of long COVID patients are being referred to rehabilitation services. And this period is already a very confusing and stressful period for these patients, given that they don't really know what's going on. A lot in their life has changed. So not only going to work, but other aspects that can be cognitive as well. So it's to really address this the lack of referral to rehabilitation and just discuss with our physicians. And all this will allow for more effective support and better rehabilitation process for the patient. So all this kind of ties into the bigger challenge of understanding long COVID as a different and a new condition, and is even further accentuated by its recent nature.
So for the limitations of our study, we do consider the small sample size and the fact that we only offered a portrait of long COVID rehab in the Quebec context. We only recruited in the province of Quebec. We consider that an issue considered when you apply it to generalizability. However, this is not usually expected of qualitative research. Furthermore, a majority of our participants were from the private sector because we ran into a few barriers with institutional regulations with recruiting in the public sector. However, with the 9 participants that we did recruit, we did reach data saturation because we had really consistent perspectives that emerged from our studies. So we do believe that our sample size was valuable for that aspect.
And to conclude our presentation, I just want to highlight the key messages. Being the goal of returning to work is rarely attained in long COVID rehabilitation. Education should be provided as early on as possible in order to ensure sustainability of self-management and prevent the exacerbation of symptoms. And lastly, long COVID patients should effectively manage activities of daily living prior to considering a return to work. So that is our presentation. Thank you so much again for logging on and listening.
Thank you so much for the presentation. It was very clear, very well done, girls. So I think we're going to move to the questions and answers period.
Yeah, exactly. If you have any questions, please don't hesitate to maybe write it on the chat or ask us orally, and the girls will answer.
Maybe we could start with Vanessa and Mayuri. I don't know if you have received the draft of the manuscript yet, but based on what you heard today, I'm just curious to know if you felt this was helpful for you, or if you have any comments or suggestions for the students.
Je peux commencer, ça vous dérange si je vais en français, ça va être plus facile. Mais j'ai trouvé ça super intéressant. Bravo les filles, c'est un beau travail. Je pense que ça donne un bon portrait là, de ce qui est fait, puis ça ressemble un peu à ce qu'on a comme challenge ici aussi. Donc, c'est quand même pas 100% nouveau ce qu'on voit, mais c'est le fun de voir que c'est un peu généralisé partout. Moi, j'avais juste une question en lien parce que de ce que j'ai compris, tu sais, le retour au travail n'est pas toujours atteint dans la réadaptation. Mais est-ce que vous savez si c'est pas atteint parce que les gens, tu sais, mettons, au privé, souvent, ils n'ont pas, tu sais, ils ont un certain nombre de semaines, puis après ça, c'est terminé, la réadaptation. Est-ce que ça n'a pas été atteint parce qu'ils n'ont pas eu le temps ou parce que vraiment la personne était inapte à reprendre le travail?
Ça variait beaucoup, dépendamment du secteur du professionnel. Mais je sais que des fois, en privé, c'est parce qu'il y avait un certain mandat. Fait que ça faisait que, admettons, dans 6 mois, ben, il n'y avait pas de retour au travail. Puis il devait quand même arrêter les traitements là, parce que les gens continuent pas nécessairement de revenir en ergo, en physio privé pour la COVID longue, parce que c'est pas nécessairement non plus couvert par les assurances toujours.
Ouais, je peux...
Alex.
Ouais, juste ajouter un autre point. Des fois, quand on demandait c'était quoi, like, what was the biggest challenge, des fois, la réponse, c'était vraiment les symptômes. Donc, peut-être dans ces cas-là, c'était juste la condition en tant que telle est juste vraiment difficile à gérer. Que là, essayer de retourner au travail était juste très, très difficile, surtout dépendant de quel travail
était
le
fait.
client fait.
Ouais, exactement ce que j'allais ajouter. Dans le fond, c'est vraiment un peu des deux. Mais si je donne un exemple, par exemple, il y a un participant qui nommait comme quoi un client qui était enseignant, par exemple, pourrait pas retourner au travail nécessairement. Parce que la nature de son travail, c'est d'aller une journée complète. Ça se fait pas tant pour certains jobs d'aller quoi. Il y a plusieurs facteurs à prendre en considération. La nature du travail de la personne étant vraiment un gros facteur, mais un peu des deux parce que les compagnies d'assurance vont parfois restreindre le nombre de séances.
OK. Merci.
Est-ce qu'il y a d'autres questions? There is any other questions?
Sorry, if I can, sorry, I didn't raise my hand. It's Mayuri speaking. Very good presentation, girls, as well. It was very informative, but like Vanessa was saying, it's pretty much all the challenges we're facing with here as well from our few clients that we had with COVID long. Especially like for the participants that you had, 2 of them were from a rehab setting. What were their challenges in terms of where did they have to go through reorientation of employment, or did they deal mostly with insurance companies? Did you have more information on that perspective?
I don't think we didn't really like separate the data according to what setting they were in. But if I can recall, they definitely had barriers in how long they could make their rehabilitation, because a lot of them were part of like specific government funded programs that only permitted a certain amount of sessions. So that's probably the major barrier that they faced.
Okay, thank you.
I see that Suzanne has her hand raised.
Hi, thank you for the presentation. I think it's very timely for work that we're doing with our COVID long clinic at the Jewish General Hospital and the links that we're making with our partners at the Constance Lethbridge. I'm wondering, very specifically, the information that you're saying that could be provided early on in order to optimize the rehab process. Do you have specifics about what should be provided there with regards to education for these patients? Be very helpful for our clinicians who are currently doing that initial.
Yeah, so I'm going back on this slide over here. So the various topics that really came out a lot. There wasn't necessarily an order that was given for like in what order you should address these topics. Of course, it's definitely, you do it on a case-by-case basis. Like I did mention, some of them did prefer to do group interventions because it kind of, you got that like kind of reassurance and support aspect among different clients, working together and talking to one another. But ultimately, it really came down to these 6 topics over here. So making sure that the client understands the symptoms and the condition itself, which it would make sense to do that early on. And then just depending on what the client is trying to get back to, go through each of these topics one by one. Energy conservation, if they're having more respiratory issues, maybe work on some breathing techniques, and if emotions are getting in the way, work on that emotional regulation. But so it really comes down to that. Some of them also express that their clients were experiencing a lot of pain in different areas, so pain management might also be something to address.
Yeah, I think the 2 that really popped out the most, especially early on, is like the understanding long COVID, so the symptoms and the triggers, and also the energy conservation. I think those 2 came up most often in responses?
In the respondents, which were the professionals that were generally doing this type of education?
So a lot of
across the
sorry. A lot of OT and PT, especially in group interventions, would do it together, and it would even overlap sometimes. So that's what was one way to work in a multidisciplinary or interdisciplinary way. And also to expand a little bit more on what my colleague said, a lot of pamphlets, a lot of journal as well. So just write down what they're doing on each day. So then the patients could kind of learn how to look back and like, oh, okay, I experienced a malaise after doing this, or if I can do this today, then I won't be able to do this. So that will kind of fall back into the self-management as well. And for the energy conservation, a lot of it was la théorie des cuillères, so the spoon theory or the battery, just explaining to them how pace each other and stuff like that. Yeah.
Thank you.
Nancy, do you have a question?
Yes, thanks again. I echo everyone's comments. It was a very clear and concise presentation. Just piggybacking a little bit on my colleague Suzanne's comment that, we're trying to develop services and grow our offer for this, what's a new clientele to us. And I think you mentioned in another slide that the challenge of the intervenants themselves dealing with this new thing, that they reached out for resources. I'm just wondering if any of them actually mentioned like the benefits potentially of a community of practice. My thinking being, given that the evolution is different, pronouncing when someone is inapt to work, which is a very difficult decision, right? If I compare with stroke, for example, an OT could say with certain confidence if someone's 1 year post-stroke, they've measured their improvements, they've tried to benchmark, et cetera, and then it's not achievable, you could say. But given this PES factor, and we're thinking of growing our offer to almost be episodic follow-ups, because there's no point in someone continuing to therapy if they're in a plateau. But usually plateaus lead to end of services, but in this case, maybe plateaus should lead to a follow-up later just to make sure it was a real plateau. All that to say, I was wondering if they mentioned about community of practice, because to make that decision as an individual professional, whether you're at the Constance Lethbridge or in Abitibi, it can be quite difficult.
I know that one of the participants mentioned that there is a Facebook group and with a lot of OTs and PTs working with the long COVID. I don't have the name exactly, but that's what she talked about. Like when she would have a case, she would reach out to a colleague there to see if they had someone, let's say, I know she said it was hard, let's say, for a participant going back to work if he was a firefighter. So that they would discuss that on the group or individually after. But I know she like this participant in particular had people that returned to work after a little bit over 3 months, whether she had other ones that had been 2 years, and she's still seeing them at certain points. But I think they had reached the point where the person wasn't going back to work.
Thank you.
Is there any other questions? Okay, I don't think we have any more questions, so we can wrap up. Thank you to the girls for the amazing presentation. Oops, is there someone speaking? No, sorry. Thanks for the amazing presentation and the interesting results. Thanks to Mayuri and
Vanessa,
sorry, for the project and the help, and thanks Tania for also accepting conduct the project in our setting. Okay, I wish everyone a great evening and a great afternoon, in fact, and thanks again.
thanks everyone. Well done, ladies.